Hello, welcome to Psychopharmacology and your 641 case presentation presented by Veronica Forchu, DMP student with Brightman University. As we can see, the medication for this case presentation is lithium. Let's have a brief overview of the medication. Lithium is the most stabilizer, has been used since the late 1800s. Lithium was initially used to treat gout and various psychiatric disorders, and later as a maintenance drug for bipolar disorder. Lithium is used to treat and prevent episodes of mania in people with bipolar disorder. Lithium is a class of medications called antimanic agent. It works by decreasing abnormal activity in the brain. And lithium does have a narrow therapeutic index range. And lithium reduces excitatory neurotransmission. However, this broad effects are underpinned by complex neurotransmitter systems that strive to achieve homeostasis by way of compulsory changes. Case study number one: when it is appropriate to use lithium. Background: a 32-year-old Hispanic female with a 9-year history of bipolar disorder type 1, presenting with 4 severe manic episodes, recurring prolonged hospitalization in the past. Chief complaint: increased activity, energy, increased agitation, decreased need for sleep, could not stop talking, and easily distracted, wanting to become pregnant. So a little history of the present illness. Patient diagnosed has a diagnosed history of bipolar disorder for 9 years, times 9 years now, and she also wants to get pregnant. The patient has no other medical issues, denies having any allergies. Mother was diagnosed with bipolar type 1 and depression. Patient is currently taking lithium 1500 milligrams carbonate per day with normal serum level. Takes Tylenol occasionally for headache. The patient denies using drug, alcohol, denies history of substance abuse, no family history of substance abuse, and patient is 32-year-old female, married, works as an elementary school teacher. Physical exams: patient is alert and oriented times 2. She's stable right now. All review systems are negative. Viruses are normal. Lithium levels at this encounter 0.8 and has been normal in the previous month. Diagnosis: differential diagnosis: encounter bipolar 1 disorder, manic episode, severe. And differential diagnosis not limited to major depressive disorder, bipolar disorder, bipolar 2 disorder, cyclomic disorder, schizoaffective disorder, ADHA. So the treatment plan: this patient who wants to get pregnant, wants to know whether to continue lithium and having the risk of having a child with abstinence abnormality or other abnormalities. So the decision tree for potential outcomes, which are measured from 0 being the least desirable condition, patient relapses and has an abnormal child, to 10 being the best option, patient does not relapse and has a normal child. The patient and the psychiatry came to a mutual decision to assign utilities based on their therapeutic relationship, and patient know that 10 is having a normal baby, and so the patient wants to pursue having a baby and being on lithium. So why this approach is appropriate in this case is that, based on what the literature has described, approximately 21% of women who are pregnant decide to continue lithium treatment. The risk of abstinence abnormally has been described to be approximately 0.05%. And so studies have reported that the patients taking lithium, the risk of their anomalies is approximately 11%. Pregnant women with bipolar disorder have a 52% probability of experiencing recurrence of their illness during their pregnancy if lithium is discontinued. And so we see that, so the patient decides to continue lithium during her pregnancy and expect to have a normal baby. So if the patient may stop lithium, the risk of relapse within 3 months will discontinue treatment. So cultural diversity affects that patient is Hispanic female, therefore it was important to involve her in the plan just like any other patient. In research on mental health services more broadly, Hispanics have been found to seek help for psychological problems from their primary care physician and family members rather than from mental health specialists. And so the lack of care through specialized mental health providers may be a consequence of the heightened stigma towards mental health diagnosis and have been documented among Hispanic and particularly foreign-born Hispanics. So research shows that no Hispanic were receiving minimal adequate treatment for their bipolar disorder, and so future research is needed to focus in the identify this barrier. So, in conclusion, regular monitoring of serum lithium concentrations and appropriate caution should be exercised even when serum lithium concentrations are within reported therapeutic levels. And so, when lithium therapy is continued during pregnancy, regular antenatal visits are warranted for checking lithium blood levels, evaluation of fetal growth, and for monitoring signs of preterm labor. Case study number two, the case where lithium may not be appropriate. Chief complained acute mental status changes and was very lethargic. On history of present illness, patient is 70-year-old white woman. She lives alone. She was found on the floor in her apartment by a neighbor. Not sure how long she was being down. When she came in, she could not follow commands. And she was nonverbal and had generalized tremors. Her medical history: osteoarthritis, slight obesity, and bipolar disorder. Denies allergies. No history of family history of psychiatric addiction. Medications: lithium 900 milligrams PO daily. She's taken it for 5 years now. Social: she's a widow, quit smoking 10 years ago, occasional wine drinker. Her labs: lithium elevated at 2.1, greater than the maximum therapeutic level of 0.6 to 1.2. CT scan negative. Diagnosis: two top differential diagnoses include seizure activity, post-spectral state, and lithium toxicity syndrome. ICD code for lithium toxicity, you see it here, 969.8. And diagnostic and statistical manual for mental disorder, DSM-5. Treatment plan for this patient is to hold lithium, do neurological studies, monitoring, uh, her tremors continue, so an EEG was ordered and it reveals slow brain activity. Day 5, she discharged skilled nursing facility for further rehabilitation. An alternative to lithium may need to be considered for this patient because she lives alone and have difficulties with management. The long-term plan is for her to go live with her daughter, and education was provided. And make sure, it's very important to follow up with a healthcare provider for routine blood work and monitor lithium level. So, why is this approach appropriate for this case? The patient is elderly. One, she lives alone, and because lithium has a very narrow therapeutic range of 1 to 1.5, patient needs to be monitored. Toxicity is very likely if they're not monitored. So frequent monitoring through laboratory tests is recommended for this patient, which she lives alone, and so giving an alternative might be the best solution for her to avoid toxicity. Cultural diversity: despite treatment being equally effective, there are still disparities between how people of different races experience symptoms and treatment of bipolar disorder in the case we just saw. So the patient's age and ethnicity played a role in the decision to try an alternative medication. In conclusion, for this case number two, the patient presented with neurological defects and can be difficult to manage, especially the multitude of possible differential diagnoses. Some of this, such as lithium toxicity, are not common. However, it is extremely important for healthcare providers to recognize and treat lithium toxicity as soon as possible to prevent irreversible symptoms. Patients should all education. The patient should notify the healthcare provider immediately if they have any of the following possible symptoms: diarrhea, nausea, and vomiting, drowsiness, blurred vision, slurred speech, and the patient needs to know that toxicity could develop as a result of illness and heavy sweating. Adequate fluid intake is recommended. Avoid heavy exercises. Sodium intake should be consistent because any changes may affect renal elimination. Patient education continues, just emphasizing on fluid intake and adequate sodium intake. Lesson learned: the physician must determine whether the benefit harm balance of the medication applies to individual patients, and they often rely on medications that are most familiar with. Factors such as age, gender, ethnicity, family background, comorbidities, polypharmacy to play a significant role in determining a prescriber's decision to treat with a certain medication over another. We have come to the end of this presentation. Here are the references. Thank you for watching.